Welcome everyone to our next live EP coming to you from the halls of Subang Jaya Medical Center. This is the SJMC Cardiology Grand Round number 13, and we are continuing from the previous one, and this is entitled Patient's Journey Part 2. So before I hand you over to the cardiology team, just some housekeeping slides, okay? So we are going to have Q&A on the Slido preferably, but we are also only broadcasting this time only to YouTube. So if you like to ask questions, you can do so on YouTube, and even those who are in the panel can also type text to answer you there, or we will bring it out and we'll answer verbally, and the Q&A will be at the end of the session. But please, if you could join us on slido.com, the code is 363889, or you scan this QR code, it will take you to the slido.com Q&A session, okay? The CPD points would be awarded by displaying a QR code at the end of the talk. This QR code will be valid for 1 hour, so at the end of this 1 hour, you will not be able to claim the points anymore. However, code words would be used, and we will display these code words throughout the talk, so you please take note of the code words, and if you are unable to scan the QR code, or you have watched this CPD session after
there's a patient that I refer, but I'm about to go to do a talk. Is it urgent?
Yeah. So you can claim the CPD points by going to the forum and answer the MCQs there, and you'll be able to claim your points. Okay, and we'll display the QR code here at the end of the session. All right. So without further ado, let me introduce you to my colleagues. Let me see, it's a nice one. So Dr. Jayamala is the chair session, and she's got a very nice lake view in the background. She's somewhere in Bali, I hear. Okay. Lake Kenya. Lake Kenya. Okay. Shall I?
Thank you very much.
Shall I start your screen share?
Yes, please.
Okay.
A very good afternoon to all of you, and thank you very much, Ellen, for introducing us. This is a continuation of our last SJMC Cardiology Grand Round. This is Grand Round number 13. Okay, just to recap, that this is part 2, last time was part 1. Recap from part 1. The gentleman was 56 years old. He had no symptoms, but his friend died of an MI, so he wanted to have a checkup. He was a non-smoker, he was overweight, his blood pressure was on the high, he had pre-diabetes, and his lipids are as shown, and his liver enzymes were also a bit deranged. And this is a summary from what we discussed. We discussed about the diagnosis of diabetes, the role of oral glucose tolerance test, and 2-hour postprandial, the management of metabolic syndrome, pre-diabetes, lipids, blood pressure, and abnormal liver function tests, which are due to non-alcoholic steatohepatitis. We talked about CV risk versus presence of coronary artery disease, and how you would assess an individual for cardiac risk by doing a number of tests, some of which were to test for the presence of myocardial ischemia, and some are to look for the presence of anatomical blocks. And it's a summary. A person coming to a cardiologist may be asymptomatic, like our man. He may be symptomatic with typical symptoms of ischemia or atypical symptoms. If typical symptoms, depending on the severity, one may advise a coronary angiogram straight away for definitive diagnosis and to guide further management. Or one may do a functional test of myocardial ischemia to objectively document presence of ischemia and severity and convince the person and insurance company that symptoms are cardiac in origin. If symptoms are atypical or the patient is asymptomatic, one would assess the pre-test likelihood of coronary artery disease by using a number of CV risk assessment tools. For example, Framingham, ACC pooled equation score, and one would use tests for myocardial ischemia, and if warranted, because of a very abnormal stress test at low workloads to moderate workloads, or for whatever reason that your patient you suspect is at risk, you would go on to do an anatomical test, which is an angiogram. Whatever you do, very important, the patient must be advised on CV risk reduction, smoke cessation, treating glucose, blood pressure, and lipids to target management of metabolic syndrome, a healthy lifestyle, and weight management. So this is our man. From part 1, he was given glucophage XR 1000 noctate, atorvastatin 20 milligrams, and the journey continues. He lost to follow up. 3 years after his last visit, he turns up with vague epigastric discomfort and burping after meals. This is most marked when he goes on to take his shower. This has been going on for 3 weeks. There is some relief after taking antacids given by the doctor at his factory. However, it is still there. He claims that he can still go for his morning walks. So Navin, can I ask you, what points in a patient's history can help you differentiate between a cardiac versus a gastric pathology?
Very good afternoon, everyone. Thanks, Dr. Jaya. Okay, so when we look at the history given, it does sound like a gastric pathology. It's related to meals and relief after burping. The shower, I'm not really sure about the significance of the shower. Maybe Dr. Jaya can explain later. Was it a cold shower, hot shower? I don't know. Would it made a difference? But it's relieved by antacids. So again, it does point towards a gastric pathology. But looking at this gentleman, his age, his risk factors and all that, I wouldn't just brush it off lightly and say that this is due to gastric pathology. I think we still need to further investigate to make sure it's not a cardiac pathology. So that's my take on this.
Okay, I think what you say is quite fair. Okay, so this was a simple test that he did. He was still overweight. The blood pressure is as shown. HbA1c, liver enzymes, and lipids were there as shown, despite what he claims he has been taking his medication. So first, coming on to his symptoms. Yeah, what investigations would you think you would like to do to determine the cause? Because he might still be cardiac.
Yeah, so at this point in time, we are not sure whether he has some gastric pathology or whether he has angina, cardiac chest pain. I think we start from scratch. We could do some blood tests to make sure his cardiac enzymes are negative if we're suspecting a cardiac issue. Chest X-ray maybe, ECG, and if he's well enough to do a exercise, I would probably put him on a treadmill. And lastly, probably an echo would be quite helpful.
Okay, well, A resting ECG was normal. And yes, they put on a stress ECG. He went for 7 minutes. He achieved 90% of his maximal heart rate. No obvious STT changes. But from stage 2, he had vague chest discomfort that persisted throughout the test and slowly went away during recovery. Echo was essentially normal. So, Shamrus, in this man, Dr. Yap mentioned about cardiac biomarkers. Would you have done any cardiac biomarkers, or can you tell us something? Remember, his history is not acute, huh? Shamrus?
Can you hear me? Yeah. Hi, everyone.
Yeah,
Thanks,
I can
Dr.
hear you.
Jaya. So, I mean, if you're asking me after the stress test, would I have done the cardiac troponin? I mean, at this stage, I wouldn't do it. But in the clinical setting, if I think the history is very suspicious of ACS, before putting him on the treadmill, I would probably check his cardiac markers to make sure there's no recent myocardial necrosis before subjecting him on the treadmill. But if you're asking me after the treadmill because of the chest pain, would I have done the troponin, with normal ECG and no echo changes? I would have done it at that point. In terms of troponin generally, I mean, for the GP out there, I think it probably has a limited role to do troponin in the GP setting. What you don't want to do is to delay referral to a tertiary center, early specialist input, early diagnosis, and preventing complications from acute ACS. Sometimes logistics also a bit difficult in the GP setting to order a troponin, to follow up the results and explain it to the patient in timely manner. Sometimes even the troponin, even the first one, if it's negative, if you do it very early, you may miss an elevation in troponin. So in ER or in hospital setting, if we are very suspicious, we normally repeat the troponin 4 to 6 hours later and do a serial ECG to see whether there are any serial changes or not. So in GP setting, maybe very limited role is more to reassure you, patients presenting maybe more than 24 hours, no symptoms, ECG normal. You want to do troponin just to exclude the uncertainty that this might be a cardiac event. But to me, in a GP setting, I'll probably focus more on the history and risk factors. If I'm highly suspicious, I'll probably refer them early for further assessment and management.
Thank you, Shamrus. Now, sometimes I'm sure you've seen GPs have done troponin and results have come back a bit high. Patient doesn't have any chest pain. How do you interpret that?
Yeah, we see all these low-level rise of troponin, every day, even in our clinic, our wards. There are many other non-cardiac causes for troponin elevation also, the renal function, renal dysfunction, recent sepsis, lung-related injuries. All this can cause low-level elevation of troponin. It's not so much the level of troponin. Usually what we want to see is the rate of elevation and rate of reduction in the troponin, and take it in context with ECG and clinical history. Then you interpret the troponin findings.
Even some athletes after running the troponin.
Yes, correct. You can even get it elevated in other cardiac conditions, HOCM, hypertrophic cardiomyopathy, certain valvular condition, very severe aortic stenosis. All this, anything that can put strain on your heart can increase the troponin, not necessarily just ACS.
So what is important is the rise and fall in the levels.
Yes.
So how would you interpret this stress ECG findings, and what would you do? Yeah. First.
To keep it simple, I think if we can categorize stress tests and where this fits into, probably a stress test is either normal or positive, which is abnormal, or it's somewhere in between, which is equivocal or borderline. And I think someone who's able to exercise with good target heart rate, 90% of the maximal heart rate is doing well with no ECG changes, But then again, we can't explain why he's getting discomfort. If he has a gastric pathology, that should not cause him to have chest pain upon exercise. So in simple terms, I think it's acceptable to put him in the borderline or equivocal stress test group and probably discuss with the patient regarding what other options there are to investigate his heart further.
Anna, do you have anything to add?
I think Dato' Yap has covered most of what I wanted to say. The important thing is, this is a patient who is very high risk. So even if there's no objective changes on the treadmill, this is in particular talk about ST segment changes, the very fact that he has got some discomfort related to exertion should get all our antenna up, and we should start looking for underlying coronary artery disease. We have to realize that the accuracy of the treadmill test is only about 70%, and in even patients with triple vessel disease, the treadmill test might not reveal underlying coronary artery disease. So we have to be very, very careful.
Okay, now Shamruz, would you do a dobutamine stress echo or treadmill stress echo? Do you think it'd be useful in this patient?
I mean, given the stress test finding, I would say the normal stress test would be inconclusive or equivocal. I mean, because he has chest discomfort, I would want to know more. Stress echo is a good step-up test because it can detect regional wall motion abnormalities earlier than ST changes, and it's very specific for coronary artery disease. So I certainly wouldn't leave him alone at this point in time. I would definitely want to do a little bit more tests, and I think a stress echo or dobutamine stress echo would be a good option to consider.
Naveen, you have anything to add? Naveen? Maybe missing Naveen. Okay, never mind.
I'm back. All right.
Yeah, you're back.
Yeah, I was just saying that. Yeah, I was just saying that I would agree with Shamrose. I wouldn't stop just at the stress test because there was no ECG changes. So definitely he had some symptoms. So we can't just put that aside and stop there. And like what Shamrose had mentioned, dobutamine or exercise stress echo will definitely have better pickup rates. We're looking for something very subtle on pre and post exercise echo images. So I would definitely take the same route.
Can I add something?
Yes.
Okay, in someone high risk like this, the treadmill is already telling that something is not right. I probably will not waste time with a non-imaging test like dobutamine stress echo or a stress echo. I think in this time and age, one would say that in someone who is high risk like this, you want to do something more definitive to look at the coronary arteries, and this is where the CT angiogram would be the appropriate next step, I would think.
Yeah, fair enough. Fair enough. Okay, SP. Now, these are all his parameters. Are you happy with glucose and lipid control? SP,
Sorry.
we can't hear you.
Okay, yeah, just unmuted. Right. No, obviously not at all happy. He is. I mean, his A1C is at target. However, if you feel that there is sufficient evidence that he has got significant coronary artery disease, we know that the new recommendations are that we should start him on either SGLT2 inhibitor or a GLP-1. So even though his A1C is at target, he should initiate something that gives him target organ benefit and protection. Obviously, I think you're going to have some discussion on the LDL, which is sky high, and I think as an add-on, he's still got some significant fatty liver disease. Question 7 was, would I substitute it for glucophage? The answer is no, it would not be a substitute. I would add on top of what he is taking. If we believe that the symptomatology is cardiac in origin, I thought that perhaps when you shower and you either vasodilate, you might actually have, this would be considered as a potential sort of like worsened, precipitated by something. So we think that it's cardiac in origin symptoms. So I would not stop his glucophage. I would continue his glucophage, add on SGLT2 inhibitor.
Okay. So you would suggest, in addition to the glucophage, what? Oxida?
Yeah.
SGLT2?
SGLT2. Yes.
And you added on some medicine for your blood pressure.
Yeah. So
okay,
just to
SGLT2. Is there any advice you think you should give it?
Okay, one point to make, the glucophage you said is nocte. Actually, JR is not nocte. It has to be eaten immediately after dinner. XR is a long-acting glucophage, so you have to reassure the patient you only need to take it once a day and you'll have the effect in terms of benefit of glucose lowering for 24 hours. So they take it immediately after the dinner. The reason is because you reduce gastrointestinal side effects. When initiating an SGLT2 inhibitor in a patient, there are several cautions that we inform patients. We do mention to them that many of them will notice a little bit of polyuria, not to be too worried about that. If he's on a diuretic, even more so, that it will be a problem. In a gentleman who is not circumcised, they need to follow some perennial hygiene. Classically, we ask them to pull back the foreskin and when they pass urine and ensure that they wash every time they pass urine. Otherwise, the risk of balanitis is magnified, and that can be a very painful experience. My experience with patients who have had acute balanitis is some actually go off the SGLT2. They refuse to continue it because it is a very unpleasant experience. We do know that there is some slight increase in urinary tract infection, but it is not frequent at all. And especially in a gentleman, it's less of a concern, more so for women. Do I worry about acute renal impairment in a patient like him with normal renal function? There is absolutely no fear at all.
Thank you. Thank you very much, SP. Okay, so Troy, this is what he's on atorvastatin glucophage, and this is his complaint. He doesn't want further tests. He wants medications. What additional medications would you want to give him? SP has already given him those 4.
Yeah, thanks, Jaya. I guess it's fair enough to try medical therapy. Looking at the list of the medication that he's on right now, the first thing that I would like to add on is actually something that can lower down the LDL. He already has a little bit of hepatitis, probably due to the fatty liver. Increasing the statin dose might be a bit risky. Personally, I will probably add in an azithromycin to lower down the LDL level. That's my take. And in terms of his symptom, I guess we haven't started him on any nitrate yet. We'll give you a trial of a sublingual GTN to be used when necessary and see whether that will actually relieve him from his angina. At this point, I think the CV risk is pretty high in him. He's not on any antiplatelet yet. I would probably consider adding him on an antiplatelet, whether it's an aspirin-based or maybe clopidogrel. Yeah, these are the 3 things that I would like to consider adding on for this patient.
All right. Okay. Now, he took your GTN, he took his clopidogrel, and he got not better. He wants a definitive test. So, Kanan first. Always ask Kanan second, but today I ask Kanan first. What are the advantages and disadvantages of an invasive versus a non-invasive coronary angiogram? And maybe Troy can answer, how would you decide on your choice of angiogram?
Okay, where non-invasive angiograms are concerned, I think the first attractive thing is there's virtually no risk. And compared to an invasive angiogram, a non-invasive angiogram gives us more information than just the movement of the artery. We're able to look at the wall, we'll be able to look at the plaque, we'll be tell the characteristics of the plaque, and then you will be able to pick up a vulnerable plaque, meaning that a plaque will have the potential to rupture and cause an acute syndrome. And non-invasive angiogram will give you like areas that are difficult to visualize with an invasive angiogram, the ostium of the left knee, ostium of the right coronary artery, which can be difficult to see with an invasive angiogram. In addition, we have got anomalous vessels. The non-invasive angiogram will give you good information about the location of the anomalous vessels. The disadvantage of CT angiogram, however, is that it tends to overstate the severity of the lesion and is very dependent on the person who interprets it. It's less conclusive as compared to an invasive angiogram in determining the degree of severity of the lesion. And if there's a lot of specification, CT angiogram will not be able to enable us to evaluate the vessel. On the other hand, an invasive angiogram risk is about 0.5%, which includes things like cerebrovascular accident, death through which the heart is being passed, and things like stroke. The posture of the left main coronary artery or the right coronary artery might also be difficult to image, as I mentioned earlier. The invasive coronary angiogram is the most conclusive that we have today for evaluating the degree of stenosis of a coronary lesion.
Okay, Troy, you have anything to add, and how would you decide on your choice of angiogram?
Yeah, so I got nothing much to add in terms of the advantages and the disadvantages. For me personally, at this point, I think the CV indication risk is very high, and doing an invasive coronary angiogram gives us a better temporal resolution. It's a gold standard test, and we need to rule out whether this symptom is it actually functionally ischemic or not, or angiographically significant or not. I would straight go for the invasive coronary angiogram. And in fact, sometimes even if the invasive coronary angiogram is a bit equivocal, maybe you have a moderate lesion and not too sure whether this vessel is the culprit for its symptoms, we can also do some kind of like FFR, some kind of study during the angiogram to correlate the patient's symptom. So I will go for the coronary angiogram, invasive.
All right. So he opts for an invasive angiogram after listening to Kanan and Troy. And Navin, can you interpret the coronary angiogram? Navin?
Okay, can you guys hear me now?
Yes.
Yeah, okay. So that's the shot of the left coronary system. You can see here, this is the left anterior descending, right? And you can see there's definitely a significant stenosis at this area, right? The proximal segment, just before the bifurcation into the diagonal, right? So that's something significant, definitely more than 70%. And if you look at the picture on your right side, you can see the circumflex. I can't really see the ostium of the of the OM coming out from it. Looks disease as well, but you can see that the circumflex is totally occluded, right, from the proximal segment with some tight stenosis just before the stump. Yeah, that area.
All right. Okay, this is the right coronary artery.
Okay, again, there's a tight stenosis here at the proximal segment, bit of diffuse disease at the distal segment, nothing so significant. But clearly this gentleman has 3 vessel disease looking at his angiogram.
Okay, so basically this is triple vessel coronary artery disease. And after explaining to him, he says, I want to take medicine first. Okay, choice. What are the pros and cons of continuing with medications? And if so, what medications would you give? Is he wrong in saying that he wants to take medicine?
Yeah, so I guess it all comes down to the benefits of medical therapy in a patient with ischemic heart disease. I guess there's no dispute to actually put my foot down to say that medical treatment is very important with or without the angioplasty that the patient will actually undergo after this. So, for example, the antiplatelet, the anti-ischemic medications, cholesterol-lowering drugs. These are all the things that have been proven again and again to improve the CV outcome and also to reduce the mortality rate in a patient with significant ischemic heart disease. So nothing else to add on except from whatever that he's actually taking at the moment. Maybe a bit of Vasteral, trimetazidine to improve his symptom. Other than that, whatever he's taking right now is supposed to help him.
Okay, Kana, you want to add anything? He doesn't want to do anything else, just take medicine.
I think Joy has said just about everything. We have got several studies now which show that in patients with stable coronary artery disease, so the emphasis is on stable, that medical therapy is as good as invasive therapy. The only disadvantage probably will be the side effects of drugs, and probably medical therapy may be a little inferior in controlling symptoms as compared to interventional therapy. And in the studies, there is a higher crossover of patients on medical therapy going on to requiring invasive treatment.
Okay, now he says that, okay, if you think I need some form of treatment, revascularization, what mode of revascularization would you advise this patient? Navin first and then Kanan.
Revas, basically there's only 2 options. Either he goes for multi-vessel angioplasty, or the second option will be bypass surgery, open heart surgery. So looking at those lesions, the ones in the LAD and the RCA are fairly straightforward, right? You can see the angio again. So this can be stented easily, and also the one in the proximal RCA. The only challenge here might be the totally occluded circumflex. Again, I didn't really see a retrograde to see how big the distal circ is, but can be tried, and but it looks quite diffuse as well, the circumflex. So I think before we decide what is the best for the patient, we should actually have a discussion with the patient, with the family members, with the cardiothoracic surgeon as well, to see what is the best option for the patient. Also look at things like his syntax score, looking at his risk factors and all that before deciding what would be the best form of treatment for this gentleman.
Kanan, what is your choice for revascularization?
I think I agree with Navin that the choices are 2, and a lot of it will result from the discussion with the patient. If the patient understands, I mean, look, I can't see the angiogram very clearly, but it appears that both intervention with angioplasty as well as bypass surgery must be appropriate in this patient. If the patient understands there's going to be a higher risk of a need for revascularization because of restenosis with angioplasty, then angioplasty probably will be the way to go. Now, if he's not willing to accept any short-term shortcomings like restenosis, then one would push for bypass.
Fair enough. I think remember that he would require quite long steps. Okay, so he has stenting, and he is then discharged with cardiopulmonary plugging, atorvastatin, glucophage, telmisartan, and oxida. Shamrus, what is your advice for this patient regards physical therapy, types of therapy, and maybe Yap can tell us something about long-term prognosis? Shamrus?
Hi. In terms of physical therapy, it will depend on his angina symptoms. So maybe we recommend low to moderate intensity physical activities in all cardiac patients, at least, at least moderate for normal patients, but stable IHD, depending on the CCS angina class, is probably will be limited more by his angina and difficulty in breathing, and some of his medications, the blood pressure might be affected, In terms of targets of therapy, the LDL for him, I would keep it below 1.4. The HbA1c certainly 6.5 to 7, below 7. The blood pressure should be optimum below 130, 80. The usual, kind of stable IHD kind of targets of therapy. Long-term prognosis, as Dr. Kanan said, with recent studies in non-left main disease, medical therapy have been shown to be as good as, intervention in certain population of patients. Certainly the long-term low-rate cardiac MI is about the same between medical therapy and intervention. But certainly in terms of symptoms, intervention have been shown to be slightly better in non-left main triple vessel coronary artery disease.
Okay, specifically he says that maybe Yap can answer this. He wants to go and do running marathons now that his heart has been fixed. Is that okay?
That's a good sign, because this patient is wants to go and do exercise, which means that he's veering towards more the healthy lifestyle. So I don't see why not, if the patient can slowly build up his exercise tolerance, and eventually if he's perfusing his heart well, and if he has remains as his echo remains shows that he still has good LV function, then there's no reason why he shouldn't be doing a high level of exercise. But I think it boils down to all the things we've talked about. The long-term prognosis comes down to how his sugar control will be, how his lipid control will be. If this patient decides to pick up smoking, then of course that will worsen his prognosis long-term. But if he's able to manage his risk factors well, he maintains a good weight, is able to exercise regularly, then I think there's no reason why after revascularization that the patient can't have a very good prognosis, and for many years he may not require another angiogram, and we expect very little in-stent restenosis from the PCI. So it depends on how the patient manages his lifestyle and his risk factors from here onwards.
I want to add that we have to be cautious after revascularization. It's adequate for the patient to go on to exert himself, especially with taking up a exercise program. So whether it's going to be multi-vessel angioplasty or bypass surgery, after the healing process. And with angioplasty, generally it's about a month, and with bypass surgery, probably a bit longer. We want to subject the patient to some sort of dynamic test, like a treadmill test. And if that demonstrates there's no residual ischemia, then certainly you can go ahead and exercise to whatever limits you want.
Okay. So sometimes I get a bit worried because you've got such long stents, whether it's flexible and whether it might sometimes stretch. So sometimes I chicken out by telling my patients that certain physical activities may be better you refrain. Okay, coming on. A lot of people use Brilinta, which is ticagrelor, instead of Plavix as a second antiplatelet agent. What is your thoughts? Yep.
So if we look at the what Brilinta is basically, Brilinta versus Plavix, as compared to aspirin, the difference is that both Brilinta and Plavix are newer generation antiplatelet agents. They are specifically ADP receptor blockers. The ADP is the receptor that is actually on the platelet. So if you block this receptor, then you basically have an antiplatelet agent. Now, Brilinta is said to be more effective in actual the antiplatelet action because of specifically the target of the specific receptor within the actual ADP. So this minor difference actually makes Brilinta a more potent antiplatelet agent, which also means that you have a higher tendency to bleed. So the evidence for Brilinta compared to Plavix, Plavix has been around for a very long time. It's basically from two trials. One is actually called the Pegasus, where Brilinta was shown to be more effective than just aspirin. And also the other one is called the Plato trial. Now, the evidence basically from Plato trial is that Brilinta is more effective than Plavix in acute coronary syndrome. So specifically, we are talking about unstable angina and in non-STEMI. So if someone comes in with a positive troponin or has SC changes on the ECG, that is where we tend to use Brilinta instead of Plavix. It has a faster mode of action, and you can get antiplatelet antiplatelet action quicker and more effectively. But in the long term, I think there are some disadvantage of using Brilinta instead of Plavix. Like for example, in this situation, it is expensive. It is a twice-a-day drug, and I think for elective PCI, if they have stents, probably I would prefer just using Plavix. So it's not in the context of an acute coronary syndrome.
Yeah. So this man is actually quite stable, so it's not an acute stage. Okay, beta blockers were not given. What are your comments, Shamrus?
To be fair, I mean, when I saw the story earlier, at the beginning, when his blood pressure was about 150/80, heart rate more than 70, and he had the chest discomfort, I would probably have added beta blocker also for him to optimize his blood pressure control as well as his angina symptom. I mean, certainly the strongest evidence for beta blocker is in the setting of acute myocardial infarction and reduction in the future mortality risk. In patients with stable coronary artery disease, the data are conflicting. So it's more for angina symptom reduction. Certainly in patient post-MI, systolic dysfunction, I would certainly consider beta blocker. But for him specifically, the blood pressure wasn't optimized and he had some angina. I would have added beta blocker also.
Yep, you have anything to add?
Yeah, I agree that specific indications for beta blocker would be if you have LV dysfunction, so in heart failure, post-MI, which basically this is not. The other indications would be if the patient has persistent angina, so we will be using it as an anti-anginal agent, or if there's any arrhythmia. Of course, you know, all these things are very closely associated with ischemic heart disease, which you know, this patient has. So he could easily develop heart failure, or he could have arrhythmias somewhere down the line. But specifically now, if he's stable without angina, I think there's no need for beta blocker.
Thank you. Okay, how would you follow up these patients? How frequently, if at all, would you monitor blood parameters, ECG, stress test, or even a CT? Choi.
Yeah. So given the fact that revascularization has been performed, I would expect his symptoms to be very much better than before. I will still.
You are a bit cut off.
Sorry, can you hear me?
Yes, yes.
Sorry, I will still do a stress test about a month after the procedure, just to make sure there is no significant residual ischemia, and see whether his functional status has been improved. He stopped at stage 2 the last time, and I hope he can probably complete his stress test after the revascularization. CT angiogram, I think I won't do it routinely. With all the stents in place, I think it will actually provide very minimal information about the status of the stents. ECG, nothing routine unless he has new symptoms. And the most importantly will be the blood parameters, like what the other panelists have mentioned, the LDL-C, the sugar level. These are all the things that we have to really emphasize on when it comes back during the follow-up.
Kanan, you have anything to add?
No, nothing to add to what Choi said.
Okay. All right. He keeps his appointments, exercises. 6 months later, these are his parameters. SP, are you happy with his results? What changes, if any, would you suggest? SP?
Sorry, keep forgetting to unmute. What we have forgotten to discuss is also a lot on his weight. We need to track his weight, and I think most of you have been mentioning about his physical fitness, and that will also be sort of like part and parcel of his overall well-being. So if the A1C looks excellent, 6.1. Obviously, he is making some changes to his lifestyle, especially after having had stents done and stuff like that. So, but let me just say that if it were like this and he were able to lose weight with his lifestyle change, then I'm comfortable with this. I heard earlier on Choi mention about worry about the AST/ALT elevation, which is very common in individuals with type 2 diabetes, that they have fatty liver disease, and it should never be a concern for us to escalate statin therapy. If you want to add ezetimibe, it's fine, but his LDL is not where you want him to be, considering that he's just had his invasive procedures done. So that should actually further improve. His LDL should go down below that 1.7 that we are seeing. If, however, he is still stuck with his weight, I suppose that adding a GLP-1 may be beneficial for him. Because although we do not have any cardiovascular outcome trials to show us the benefit of dual therapy, meaning GLP-1 and SGLT2, we might start seeing some data coming up from the Amplitude O, which has a lot of patients with. Sorry. Maybe using the GLP-1 in order to get him to better weight loss would be useful. Sorry.
Okay. All right. So we move on. He was added with ezetrol, and this way is medicine. Choi, he says too much of medicine. Worried about its effect on his kidneys and sexual function. Would you want to reduce?
Yeah, so I was about to ask this question because I think it's quite a common question that you get in the clinic setting. Surprisingly, this is probably the most important thing for most patients. It's about the sexual life and sexual function. I will usually reassure the patients that, in terms of the kidneys, I think we have data to prove that at least in patients with reduced ejection fraction, SGLT2 like Forxiga, in fact, is actually very renal protective. So we will actually probably reassure him in terms of the kidney failure and all this renal injury from the drugs. Sexual function wise, he's not a beta blocker. I don't see anything in particular that stands out that can actually impede his sexual function. I would like to highlight that a very important thing that that we have to remind the patient is that if the patient intends to use sildenafil, the magic blue pill, it's important to tell the patient that you must actually run by us or any other doctors to make sure that he's not on the nitrate before he starts on the sildenafil, because we know that sometimes the BP lowering effect after he takes on the sildenafil can be quite significant, and he has been mentioned in cases where they have a CV event. But other than that, coming back to the question, I don't think there's any medication that we can reduce except one of the antiplatelet when the time comes, and it's purely to reduce bleeding risk. That's all I think.
Thank you, Choi. So, quick moving on. He remains well for 2.5 years later. Then he comes complaining of palpitations associated with dizziness. Intermittent, usually lasts for a few minutes. More frequent when he walks after a big meal and his stomach is bloated. He claims he can still jog and exercise regularly and he has no problems, although he has not been exercising much as before because of work commitments. He denies chest pains. What would you do, Nevin?
Okay, well, I think his symptoms are similar to what he had in his initial presentation, especially the gastric pathology symptoms, right? But this is something new, palpitations and also dizziness. So one of the things that the first thing I would do is probably do a blood test for him as well. He's on double antiplatelets or even a single antiplatelet now. That can actually cause gastritis or peptic ulcer disease. He could be anemic, and that can also cause the palpitations and the dizziness. Next thing I'll do is probably a simple ECG to see if there's any ischemic changes, and I will definitely put him on the treadmill again, either exercise stress test or a stress echo, and also repeat his echocardiogram to look at the LV function.
Basically, ECG was normal, hemoglobin was normal. Stress test, this time he went for 5 minutes. Stopped because he said he was unfit. Nothing, no FTT changes. Echo normal. What would you now advise him? Yep.
The scenario now is a bit different because he's not complaining of this kind of chest pain, gastric discomfort so much, but palpitations. So I would be a bit worried about arrhythmias in someone who has a history of ischemic heart disease and whether he has any ischemia, cardiac ischemia come back as well. So I probably would discuss with the patient about doing a Holter at this stage to look for arrhythmias.
So is there any association within the palpitations and stomach bloating?
Yeah. So first of all, I totally echo Dr. Yap's opinion, because in the patient with multiple stents and history of ischemic heart disease, arrhythmias is definitely something that we have to consider. And it's given the fact that he's not on any beta blocker yet, Holter would definitely be the way to go. If we see anything significant, beta blocker should be started. He's been on aspirin for quite some time, and I do see that from time to time. Some patients develop a bit of a reflux, a bit of a GI discomfort. And the funny thing about this reflux is that the esophagus being so near to the left atrium, sometimes when you have a significant reflux, the acidity in the esophagus can actually trigger off a couple of extra heartbeats from the pulmonary veins, and patients actually do have a bit of atrial arrhythmias because of reflux. So for me, if he had stomach bloating and with a background history of a cardiopathy for quite some time, I sometimes give a bit of PPI to see whether all these symptoms go away, including his palpitation. Who knows, it could be just a reflux.
Okay, we are a bit pressed for time, but maybe I will just pass on first. Well, he had the CT angiogram done. Okay, so because he had long stents, just to tell you, it's a very difficult sometimes to evaluate stents. This is not the patient's stent, but just to tell you what a patent stent looks like and what there's restenosis. Well, this patient had a Holter, and it showed some ectopics, and he had a CT angiogram, which showed that he had severe restenosis in the RCA and moderate restenosis in his LED stent. Okay, Shamruz and Nevin, what is your advice to this patient now, 2.5 years after his stent?
Well, I'll definitely advise him needs to repeat the angiogram now that the CT scan has shown something. So that's probably the cause of all his symptoms. So that will be my short and sweet advice to him.
And if there's restenosis, it confirms what you see, what would you advise?
Well, then again, it depends on the extent of the disease. If it's just within one stent, we can probably try, a drug-coated balloon or something. But if it's something very diffuse, then probably I will refer him for a bypass surgery.
The question is why. Yeah, the question is why has it progressed so much? In 2 years, I mean, his HbA1c was 6.1. Was it because the LDL was still 1.7? Do we need to get it very, very low? It's in 2 years, he's already got this progression of his diseases. So certainly the long-term plan will depend on the coronary angiogram finding, as Navin said.
I think the restenosis is not dependent on LDL levels. It's probably part and parcel of the patient's status and the stents, etc.
That's right, yeah.
Okay, so this last question to Troy, not for this patient, but in what conditions would you consider radiofrequency ablation for arrhythmias?
Okay, I guess the short answer will be the most important thing is symptom. We are not talking about this patient, right, Dr. Jaya? So
no, not this patient.
Yeah, in general, anybody who comes in with arrhythmia and is very symptomatic, of course, there's always a role of radiofrequency ablation, especially if you have exhausted all sorts of medical treatment. The second indication is when the arrhythmia actually leads to heart failure. I think the standard example to give will be AF, atrial fibrillation, and heart failure. Many trials have proven that if you consider radiofrequency ablation early in this group of patients, the outcome is usually very good. And we also talk about the mortality benefit as well. The third thing will be even benign arrhythmias like PVCs and VT. If the PVC burden is very high and the patient is very symptomatic and couldn't tolerate, young patients, you give them beta blockers or any of the anti-arrhythmias, it's very poorly tolerated, then of course radiofrequency ablation can be considered.
Okay, now in the interest of time, we will just summarize. So this patient had atypical symptoms, but is high risk for a CV event. And from part 1, we know that if the atypical symptoms or asymptomatic, you would do a test of myocardial ischemia, but your threshold for this patient to do an angiogram would be very low. And he was found to have triple vessel disease, and we did discuss about just medical therapy versus revascularization. The indication for revascularization would be persistent symptoms affecting quality of life despite medications, significant left main stent stenosis, large areas of myocardial ischemia as shown by very abnormal stress tests or cardiac nuclear scans, depressed LV function. These would be indications that you would consider for revascularization. And in a patient with palpitation, well, you would want to know what the type is. You want to treat the etiology. And in this case, in my patient, it was because of coronary artery disease, restenosis, and therefore ischemia. And you would treat depending upon the cause. So whichever patient, remember, it is a progressive disease, and all patients should be advised on CV risk reduction methods. So thank you very much again from us at SJMC. Back to you, Alan.
Thanks, Jaya. I think it's now time for Q&A. So got any questions, please post either in Slido. And this time we are only broadcasting in YouTube, so we're not broadcasting in Facebook. please post your questions in the YouTube comments, the live chat there. So could you please, there's one question from Dr. Shasmin. How about the use of TPI in view of double antiplatelets to improve his quality of life?
Okay, that means prophylactically giving PPI in patients on dual antiplatelet agents. Okay, some people would routinely give it because you want to reduce the risk of bleeding, especially if you think your patient is at a high bleeding risk. Number two, you will also be a bit cautious about using long-term PPIs because that too has its side effects. And number three, your patient is not going to be happy with too many medications and of course the inherent costs of all these medications. Yes, there's a role, but maybe not for every patient.
Okay. In the Slido, there's no question.
Okay,
no
great.
questions in the Slido.
Okay.
I just have to apologize. I was looking. The MMA system has changed a bit. They've overhauled the app, and now the provider cannot change the date of the presentation is fixed also. So I'm not sure that's why I didn't put the keywords there. So I'm afraid you can only claim points by scanning for this event until I try to sort out with the MMA how it can work. Because if you're trying to claim later and the event is over, it may not work using keywords. The other thing is if you can't scan, then I think maybe you can contact our SJMC coordinator. I think Janet. We've got a new coordinator, Janet. So those of you who have registered for the event, the registration form was in the page. Janet will help you get your point. Otherwise, I think we will go on to the QR code.
Yeah, you put the QR code.
Yeah. Okay, so we hope it will work also because like yesterday there were some problems with people claiming points because of the overhaul of the MMA app. There's still some issues there, but let's see whether we all can scan, yeah? Me included.
Yes, success. So it works.
It works. Well done. Yeah. How come we took photo? Let's see. Scan.
Yes.
Yeah, I got my point too. So MMA app works. Yes. At least for us. Yeah.
I can't get mine. Jared must get.
No, you took photo, Kalam. You need to use the QR code.
No, I know.
Okay. So please WhatsApp the GPs who couldn't claim. Please ask Janet to help with the.
Janet, you can do it.
Yeah. So Janet will help you with the links. Thanks very much, Janet. Okay. Yes, Sunita, MS Viewmon, whoever you are. Yes, can scan. Thanks for the feedback. Hope everyone enjoyed it. We are going to focus, I think, only on YouTube because Facebook has some issues, I think, with the commenting. We cannot reply, whereas YouTube, we can reply to you directly on the chat. And also, the notification, sometimes you get lost in the Facebook, too many things in your feed and you forget about it. So please, best thing is please subscribe to our YouTube channel. Please subscribe to our YouTube channel and do like the video, okay? The smash, as they say, smash the like button, subscribe to our channel so you will never, miss a notification when we schedule something live, okay? So I think we'll change it like that. And you can watch this again. I'm sorry, the code words, I could not display them until I tried to sort out with the MMA how it can be done. Okay. So if that
thank you very much.
Yeah, so thanks to all the participants, thanks to our moderator, Dr. Jayamala. So we'll see you again in the next one. All right. Take care. Bye-bye. Okay.
Bye. Bye.